Thanks to everybody, especially Jerry and the ASAP folks for inviting me here today. It's truly an honor and a privilege to be here. And I've done this for a number of years, and I always find I come back with a lot more information than when I went out with. So for me, personally, it's a great thing, and it's a pleasure being able to work with the patients, the parents, the kids, and all that sort of thing as well. So this is important on my end. So I've been tasked today to kind of give you an overview about tonsil manipulation, or what do we do with the cerebellar tonsils. And I think most of you guys in the room know what we're talking about, cerebellar tonsils, not throat tonsils. And the question is, where are we today with the shrinkage factor? This is part of it. We have no conflicts of interest. It's an IRB study. And really, at this point in time, we have an IRB, we have a pilot study from ASAP to look at this and try to figure out how do these patients do when we have somehow affected their tonsils, whether they shrink them, resect them, and so forth. And, I'm sorry, I think I put that in the wrong order, Jerry, for the shrinkage factor question here, but nevertheless. So we're going to talk a little about Chiari. Overruled. We're going to talk a little about Chiari. It's going to define it. We're going to talk about some of the potential etiologies, why the tonsils are low, and I think that's a big part of this. I'm going to give you a little bit of an overview of the literature. And the literature, it's interesting. It's all over the place in this. And we give you a little bit of a snapshot of our 25-plus year at Children's with Chiari's, and talk about how we've changed our approach to this, what do we do with the tonsils, and so forth, and talk about long-term outcomes, complications, and so forth. And my role here is to try to keep this interesting, try to add to somewhat of the controversy and so forth. So I think you have to ask yourself, and again, I think everybody in this room understands this question pretty well. You're all veterans, you're all experts. What is a Chiari malformation? Is this a clinical condition or is it an X-ray finding? And again, you heard some great talks yesterday about the radiographic presentations and so forth. And is it different for different ages? Does it change over time? Does it evolve as the patients get older? Or is it perhaps driven by the etiology or the reason why the cerebellar tonsils are low? So again, I think everybody knows it's tonsils that are 5 or more millimeters below the foramen magnum. This is defined years ago in a paper that looked at norms and looked at 2 standard deviations. That's where they came up with the number 5. And again, there's Chiari 1.5s, Chiari 2s, 1.786. I mean, there's all kinds of variations on this, and it's kind of hard to know what it means. But the real question is, does this reflect a different disease for different ages, or does it reflect different etiologies? And we put this out last year, and a number of folks in this room were part of this paper looking at kids versus adults. They're totally different. And you heard yesterday, and you'll hear today and probably tomorrow as well, talking about hypermobility, Ehlers-Danlos, and all that sort of thing. Different conditions with a similar radiographic picture, but it doesn't mean it's the same thing. So we know in the regular population, I think Jerry's talking about this later on, the natural history, this is out there. 1 to 2% of patients will have a Chiari and not know it. These kids come in all the time. It's found during a workup, and the question is, what do you do with this? Fortunately, a small percentage of these patients become symptomatic. And a paper we put out a few years ago, we looked at these kids long-term over a 20-year time frame. And if you didn't have a syrinx when you presented, and this was truly an incident finding, under 4% of these patients went on to get into trouble over a 20-year time frame. So it's out there, but fortunately it's not something we see frequently. So I always try to go back and say, what is the likely reason why the cerebellar tonsils are low? Is it because the posterior fossa is too small? I think John Heiss is going to talk about that a little bit later on this morning. Is it because there's a spinal fluid outflow obstruction? Probably the most frequent manifestations of why the tonsils are low. Is it that there's pressure above the supratentorial parment? We have kids that have craniosynostosis, early fusion of their sutures in their head, and because of that, they have pressure, and the pressure pushes the tonsils down. Patients with pseudotumor, some of you are well aware of what that's all about. You address those issues. And then, of course, there's unfortunately the patients that have the hypermobility, the connective tissue variants with all the comorbidities that you heard Fraser Henderson talk about yesterday. And these patients, for reasons we don't truly understand, also have a higher likelihood of having a Chiari malformation. So whatever the etiology is, it's likely to involve some type of abnormality or perturbation in spinal fluid flow and compartmental pressures. And I think at the end of the day, unless you have an idea of what you're dealing with, why it's causing the tonsils to be low, you probably don't have a good idea how to fix that. So when it comes to surgical treatment, these are patients with intractable symptoms, patients with neurological deficits, patients with Syringomyelia. The treatment is definitive surgical, and one has a number of ways of approaching this. You can do bone only. where you don't touch the dura. You can take the dura apart where you take the outer leaf off and leave the inner leaf on. You can open the dura with or without graft, which is the mainstay for most folks. You can shrink the tonsils or address the tonsils themselves, and then there's fourth ventricular stents. At the end of the day, your goal is to restore normal CSF flow, normal anatomic parameters, make the craniocervical junction bigger, more space. And ultimately, in this process, your goal is to minimize the formation of scarring or arachnoid adhesions. This is the choke point of CSF production coming out of the head, going down the thecal sac. So as we talked about open versus closed, that debate I think is pretty much over. We'll talk about that in a second. What about intraoperative imaging, using that as a guide to figure out, do we need to open the dura or not? What do you do with the tonsils? What about the duroplasty? And then even the setting of some folks' fusions. So this is a study that came out with the Park-Reeves Consortium in the last year. This is a group of 65 centers. Lots of folks in this room are involved with this. And they looked at the data, and they looked at patients that had just the bone and the patients that had the dura open, and looked at long-term outcomes. And you can see that most of the patients that had the dura open were 83% of those patients, so that seems to be the most prevalent way of dealing with this. But they looked at this over time, and the bottom line is, if you don't open the dura, your hospital stay is shorter, your post-op complications are lower at 13.7%, but you do have a higher revision rate at roughly 18%. If you do open the dura, you have a chance of having an intraoperative complication, and then your post-op complications are higher at roughly 24%, but you have less revisions. And they also looked at it, when they looked at it from a standpoint clinically, how do the patients do? They were pretty similar between the two groups, except for syrinxes. And again, if you had a large syrinx, you did better with the dura being open. They didn't talk about small syrinxes, so it's not perfect, but that's what they came up with. And I think most of us understand this now and follow this. So with the tonsils, you can leave them alone, look at them. You can shrink them a little bit. You can shrink them a lot. You can resect them. People do that as well. Bottom line is you got to look at what are the risks, what are the benefits. We do that all the time with surgery, especially with the tonsils. So I would ask you the question, does it really make sense to create more scarring, healing, adhesions at really the craniocervical choke point of cerebral-spinal fluid flow? And I can't say it better than Ed Oldfield, and God knows John Heiss especially. We all know that Dr. Oldfield was one of the giants in the Chiari world. He felt it was unnecessary, and there are a number of folks out there who would feel the same way. So what are the potential pros for opening up or addressing the tonsils, doing something to the tonsils? Well, the x-rays look better. And of course, the x-rays tell you everything, right? It does potentially open up spinal fluid pathways, which is potentially where the issues are. You can create or increase the craniocervical volume, which is a basic tenet of what we do when we're dealing with craniofacial, with Chiari surgery. And of course, do you really need them? And they're going to cause a problem in the long term. Why don't we just take them out and not have to worry about that? What are the downsides? Well, certainly every time you open the dura, you run into a risk of having injury to the blood supply, ischemic changes, and so forth. Certainly can injure the brainstem. You obviously increase the chance of having a spinal fluid flow by opening up the dura and potentially doing something to the tonsils. And ultimately, I think you increase the likelihood of scarring, which this is a patient that came to me from elsewhere where they've addressed the tonsils. You can see that white band across the top right here. That's what's left of the tonsils, and this patient was tethered at the brainstem because of this. You are destroying brain tissue. I think most neurosurgeons try to avoid doing that. And then what about the long term? What do they do about redos? Are these patients that are higher risk for coming back later with a scarring? I think the literature is helpful to go through very quickly. Just what do we know? What have we written about over time? A thumbs up means it supports manipulation. A thumbs down means it does not. This is a paper that came out, Dr. Lazarev was here, where they just did the tonsils themselves. They did not do any bone work, and it was just a question of the tonsils are the problem. Let's address that. And in this case, 7 of their 8 patients had the syrinx improving, and patients generally did quite well. So this would be a thumbs up for doing something with the tonsils. This is a paper from NIH. John Heiss up there on the top is the first author, Dr. Oldfield. And again, they looked at their redos, and they found most of these patients had some element of adhesion scarring at the foramen magnum, and that's why they were coming back for a redo. So thumbs down. This is a study that came out. Brandon Roque from Alabama put this together after one of our pediatric senior meetings. Tim George, John Kessel, and Benny was involved with this. And back in 2011, anywhere from 27 to 42% of senior pediatric neurosurgeons did something with the tonsils. So pretty routine, pretty common. This is a paper from Jerry Oakes, one of the giants in the Chiari world, 500 plus patients. And Jerry said they only 10% of the time they even touched the tonsils, and yet they had 85% of the patients getting better with a admirable 3% reoperation rate. Clay Clamp, again, you heard yesterday from Fraser, one of the giants in the field of Chiari. Again, when they looked at the patients that had recurrences, and this, they certainly knew what they were doing, but when they had patients coming back, the majority of them had some element of arachnoid adhesions, presumably from the work that they had done there. This is another paper, the 3 Rs or the triple Rs, where they looked at reposition of the tonsils, reduction, removal of the tonsils. And again, this is an operation where they don't really do any bone work, minimal bone work. It's pretty much just addressing the tonsils as the cause of the problem. And the patients that had repositioning reduction, all of them improved. The patients had resection, only 1 of the 3 improved. So small numbers, but you can argue maybe that too much is not good for the patient with scarring and so forth. George Jallow, when he was at Hopkins, looked at this a while back and said, and when they looked at their patients where they addressed the tonsils and reduced them, shrunk them and whatnot, those patients actually did better as far as reoperation rates in the long run. So they thought the tonsil reduction and manipulation was to their advantage. This came out of Shanghai, where they saw the patients that had no tonsillar involvement, no tonsillar reduction, that 82% of the patients got better versus 64% that had tonsils being addressed. And they noted that their morbidity, their complication rate was higher when they had tonsillar manipulation. Again, not a huge surprise. And in this study, they had more patients with tonsil reduction, had more patients with meningitis, but they didn't see any difference in improvement as far as outcomes, complications, other than the aseptic meningitis. They all did relatively well. And this is a paper that Benny put together with a number of folks, again, in this room as well, looking at kids that had tonsil reduction versus patients that didn't. And they didn't see any difference in the improvement between the kids that had the tonsils manipulated or not. And so they felt that there really was no benefit demonstrated by addressing or looking at the tonsil manipulation. There was no long-term data, however, looking at was there a cost to doing something to the tonsils. And this is a meta-analysis, 15 large studies. Again, they didn't see any difference between addressing the tonsils or not. They felt that it didn't make a difference one way or the other. MRI studies after the fact show that a large number of these patients have edema, have hemorrhages in that area. So there's things that we're definitely doing, and in the long run, it's going to contribute to scarring. And then this is the latest paper from Dale Swift and the folks down in Texas, and they looked at the patients treated without any tonsillar touching, with arachnoid dissection, minimal tonsil manipulation, with coagulation resection. And at the end of the day, they felt the patients that actually had tonsillar manipulation did better when it came to the syrinx. But again, there's a lot of pieces missing in all this, but they felt it was helpful. So lots of problems with the literature. Bottom line is that they're all over the place. There's studies that say you should do it. There's studies that you shouldn't do it. Numbers are generally small. The follow-ups are really very, very short, and you need to look at this over a longer period of time. And the adults are often mixed in with the kids. I think we lost the mic. Hopefully you can still hear me. And when you talk about tonsil manipulation, what does that mean? I mean, there's times that people just look at it briefly. There's times they really shrink it for 20 minutes till it's completely gone. It's hard to know when you look at these studies, what are they actually doing with respect to the tonsils? It's a subjective rather than an objective issue. So we wanted to look at this many, many years ago. We looked at this because we thought we had kids doing poorer after the tonsils had been manipulated. And this was a study that we presented in Israel in 2018. And the bottom line is we went back, we kind of broke it down at before 2008, retrospective data that has its challenges, I think everybody knows, and prospective data beyond. But we were using cautery less on the tonsils at that point in time. And so when we looked at this, we noted that the patients in the earlier time frame, the rest of it had 74% of the time the tonsils were coagulated, whereas in the more recent time frame, only 42% had that. And what was interesting when we looked at the number of patients returning for redos, the failure of this operation was 23.8% for patients that had tonsillar manipulation versus 9%. And it's also interesting to look at this and see the bone only, where you've obviously not touched the tonsils, was very similar to the patients where the tonsils weren't manipulated. So we thought this was a meaningful number and pointed out that clearly this was not to the patient's advantage to address the tonsils. So recently, we wanted to look at, well, it's been 5 years. Have things changed? Does the data still hold up? So we went back, and this is what I'll share with our experience now for the last 20-some plus years. So over this time frame, what is that, 27 years, something like that, we've done over 300 Chiaris. You can see the red is just bone only, and the yellow is opening the dura. And you can see that roughly in this group, 36% of the whole, but 2/3 of them had tonsil manipulation, that the dura was open, and 1/3 did not. When we look at the case type or time period, hasn't really changed that much. Statistically, it's about the same. You can see that roughly a little less than half of our patients have bone only, and the other half have the dura open. And again, most of the time the dura is open, they do have some element of tonsil manipulation. The surgical indications haven't changed over time. More often than not, it's a syrinx, and you can see it's roughly in the 60 or 2/3 category. So there's no difference here between the time frames. And again, we wanted to look at kids that had the tonsils manipulated versus ones that didn't when the dura was open, using prospective data. So that's the more recent time frame. And so again, when we look at these groups from a statistical standpoint, the demographics, about the same. There's no statistical difference. When we look at the reasons, the clinical symptomatology, why they had surgery, no statistical difference. When we look at the radiographic findings, 2/3 had syrinxes, about 8% had hydrocephalus. Again, no difference between the two groups where the tonsils were manipulated versus not. When we look at the extent of tonsillar herniation, again, on the far left on this slide, you can see that for the most part, most of these patients have tonsils somewhere between 10 and 20 millimeters below the foramen magnum. But when you look on the part on the right part of the slide, if you had tonsils more than 20 millimeters below the foramen magnum, 100% of those patients ended up getting tonsil manipulation. Again, anatomically, that makes sense. When we looked at post-op stay, again, time frames were about the same. The complication rates were similar, at least statistically, and even the need for revision slightly higher in the bone only versus the dural operations, but statistically about the same. What we did notice over time is that the length of stay had decreased. And again, this is all patients we're looking at. Yeah, again, it doesn't show up as well as the thing. Looking at the redo rates, we can see here, the complication rates, we can see that that's dropped over time. When we look at the early complications, the one thing that jumps out is the red bar there. That's bone only. And that, I think, is an aberration because we were having pseudomeningocele, not necessarily a leak per se. But other than that, for the CSF issues, things were about the same between the two groups. And when we look at how do they do with respect to whether it was a syrinx, a neurological deficit, or a headache, again, between the two groups, touching the tonsils, not touching the tonsils, the results are about the same. And here's your reoperation rate, which over time has considerably come down from 15 to 6 to 4%. And that's part of our problem is our reoperation rate is so low now, we're not generating enough numbers to really know statistically if there's a difference or not. And if we look at procedure types, so you can see here the tonsil manipulation is the orangey button and whatnot. In the last 2008 to 17, we had no reoperation rates for the bone only and only 2% for the other, and the same thing for the more recent time frame. So you can argue that there's a slight meaningful increase in the reoperation rate, but I would say statistically, again, there's no difference between the two. And if we look at this is just looking at the number of cases, complications, reoperations. You can see with the far right there, the complication rate is higher for the bone only, but the majority of those were pseudomeningoceles that did not translate into additional surgery or something else. But what I want to point out is the bottom of the slide is the time frame. Follow-up is 95 months on average, 48 months, and we're less than 2 years in the more recent stuff. And this is problematic because if you look back at the middle time frame here, 2008 to 17, on average, the patients returned after 7.5 to 8 years for their second operation. And we don't have enough time to be able to say that that's an issue or not. And definitely the reoperation rates, as you saw earlier, have been statistically coming down. So to conclude, there's no question that our rate is reduced over time, and I think that's a good thing. And is it because we have a better selection of what surgical approach we're going to use? Are we getting better with the intraoperative ultrasound and trying to figure out who needs to have the dura opened or not? Older surgeons, more experience. So I think there's a lot of factors and we haven't been able to figure out why, but I think we're down to single digits and that's a good thing. I don't see, and I know Paolo is smiling at this, I don't see a disadvantage to doing a tonsil manipulation, so I can't really critique the guys that do it. On the other hand, I don't necessarily see an advantage, and I think until you have longer data and more data, you're not going to know, are we paying a price 6, 7, 8 years later when these patients are coming back for a second surgery. And I've seen, anecdotally, I've seen many of these patients coming from elsewhere 5, 6, 7 years earlier whose craniocervical junctions are locked in scar tissue and having issues and problems because of that. And I think on the long run, we need more than one institution. This is all pilot project funded by ASAP. So we have another 12, 13 institutions that are very interested in getting involved with this, and we need obviously more data. So I think it's important if you look at your Chiari patients have a radiographic definition. I always try to say, why are the tonsils low? And there are often, many times, you'll be surprised the patients have pansynostosis, where their cranial sutures are fused early. They may have pseudotumor. It isn't always as clear-cut as you think. And once you know or think you know what's causing that, then I think that's really what drives your decision. Do I want to open the dura? What statistically are the benefits of opening the dura, the success rate, and all that type of stuff before deciding on an approach? So this is Benny's paper where they looked at it. And so I found very interesting, and I'll take this to heart, they had a number of challenges just with a single institution, and we experienced some of the same challenges. Patient recruitment's always challenging, getting enough patients, the data entry problems. You know, the scary thing is I have full-time people doing all the stats and all the numbers crunching, and every time I tell them to run another thing, the numbers come out different every single time. They're close and they're meaningfully real, but at the end of the day, statistical analysis can be very challenging. The protocols change, they move around a little bit depending on how many people are involved, and ultimately there's some inconsistencies. Somebody might do something one day and they do something completely different the other day. So it's not easy putting together something that is scientifically meaningful, strict in its statistical analysis without lots of numbers and lots of institutions. So you're not going to know the whole story until we have more data and more time. And in the future, we're hoping to wrap this up soon so we can make sure we have an idea of what to present to these other institutions. We're now looking at the outcomes with tonsil manipulation versus no manipulation via the likelihood for the etiology. We have these centers involved. We're going to send this out very soon, have them on board with a red cap data sheet, and then wait for any instructions for the institutions before we finally go on to a final overview. We are starting to look at the volumetric changes in the tonsils. Again, sounds simple. It's not as easy as you think, but how much tonsil was removed to try to assess, some objective measure on the degree of tonsil involvement. And we're also working on, we have a guy that's very much into AI, real-time video analysis, figuring out how much manipulation of the tonsils actually occurred, again, objectively rather than a little bit, not so much. And so we're working on that, and we'll pass that out to the centers who are involved as well. So I'm going to stop there, and hopefully I've left some time for questions, or we can do that at the end. But thank you very much.